Hello, everyone, and welcome to our webinar today entitled Top 10 for 10-1, Top CMS Changes Scheduled for Implementation this October. My name is Ken Bell. I'm the Marketing Executive for Simple and for NetSmart. I want to thank you for joining us today for this free training. So today is September 14th, and that means it's 17 days until MDS version 1.18.11 becomes official on October 1st. So with this new version comes an unprecedented amount of change, as we all know. And so today, Simple is partnering with QRM for a countdown of the top 10 CMS changes coming in 17 days. And so we're excited because this is more than just a webinar. QRM has worked to put together a whole team of clinicians and leaders to discuss these new CMS changes that will impact us most. So whether you're concerned about the regulatory impact or you just want deeper insight into what's really coming, you're in the right place for today. So thanks for being here. And Simple, we're your host today. We're excited to be here and offer this training in partnership with QRM. And as part of NetSmart, Simple provides MDS, PBJ, and claims analytics to over half the SNFs in the country. And then toward the end of the presentation today, I'll tell you how you can get some more information on Simple as well as QRM. And speaking of QRM, we're super excited to partner again with them. QRM is Quality Rehab Management, and they're working with us today to offer this training, and we'll dive into the content in just a moment. But first, just a couple of quick housekeeping notes. So I see several people in the chat are already asking for the handouts. We do have those available. Sam will post a link in the chat for those. So hit the chat button, and then you can download those in PDF format. And as far as questions and answers go, you can ask a question at any time during the webinar. Please use the Q&A button for that. Hit Q&A, type your question there. We do have some time reserved for questions at the end today, and our speakers will address as many of those as possible. We do have a lot to cover today, and as you may have seen, we've extended this actually from 60 minutes to 90 minutes because there's so much important content. So be sure to hang on, especially through the end in the Q&A section, because there will be some really important information coming. Now, I'd like to go ahead and introduce our speakers for today. So first of all, with QRM is Susan Kroll. Many of you know Susan and have participated in her training before. Susan is the Chief Strategy Officer with QRM. She will be moderating our discussion today and counting down our top 10 list of the big changes coming. Also with us today is Mark Hyder. Mark is the Vice President of Reimbursement Strategy and Education with QRM. Also with us is Megan Ussery. Megan is Director of Clinical Reimbursement with QRM. And Stacy Grondel is the Director of Clinical Reimbursement with QRM. So that's your QRM team. And also standing by is Ethan Tain. Ethan is with Simple. He is our Senior Solution Strategist on the Simple Analyzer side. And so he may chime in from time to time on a few of these issues as they relate specifically to Simple clients. So again, welcome everyone. We got a huge audience today. We're super excited about this. So let's kick it off. Susan, over to you.
Thank you, Ken. We appreciate all of you so much for joining us and this opportunity to chat. So we're going to jump right into our American Top 10 for 10-1. Of the hundreds of releases that are coming at us on 10-1, we'll hear the latest on our top 10 countdown from our MDS superstars, Mark Hyder, Stacy Grondel, and Megan Ussery. So let's head to the top 10 billboard and count down from 10 to 1 to find out which is the biggest hit of them all. Number 10, new resident interview questions. We're going to start right out of the gate with a polling question. We want to know which questions on the MDS are you not allowed to ask anyone else when the resident declines to answer. So you've got A through F. Go ahead and take a stab at that. And while you're checking on those answers, we're going to defer to Stacy here to follow up in just a second. But we're going to, we're really looking at some big changes on the interview front, right? We've got new required interviews and some very specific instructions surrounding who can help answer the questions and when the questioning needs to stop. So we really do appreciate Stacy's help and insight in just a second to help highlight the changes and make sure that we're really clear on the instructions in just a second. So as you're answering this, we're going to let Ken pull up the answer in just a second, and then I'll pitch it over to Stacy to talk a little bit more.
Okay, it looks like we've got a good proportion of our audience who's answered, so I'll end this poll and then I'll share those results.
Perfect. Look at that. Look at that.
Very good.
All
Very good.
right. Thank you. All right. So, Stacy, I'm going to advance my slide over here and kick it to you.
Thank you. Thank you very much. So it looks like most of you understand, the majority of you got it correct. It is all of the above. It's very clear that CMS is wanting to hear more of the resident voice. They're really pushing for that resident center. And a huge part of that is hearing the resident voice. And so they're adding all of these new questions to the MDS, or taking old questions and saying, now you have to get this information from the resident. So the resident response questions can be a little tricky. There are some that allow us to use other sources if the resident is unable to answer, such as your ethnicity or the race. And then there are questions that don't allow us to use any other source. So this would be like your health literacy or your social isolation. The symbol that we have had up on the screen, that is the symbol that's all throughout the MDS, the RAI manual, and that indicates that these are resident interview questions. So pay special attention to these questions, because they're there for a reason, and there are very specific instructions for how you can answer these. So look for the symbol throughout, and those will indicate it's a resident response question. So pay attention to those and know what the look back period is, but then also have a strategy in your facility of who's going to gather this information. I was actually just interacting with a facility a couple of weeks ago, and I had asked them, moving forward with these new changes, who is going to ask the resident about ethnicity or race. And their response to me was, oh, we just get that from the face sheet. And I was like, oh my goodness, no. We have to make sure we understand the new rules that are coming up, which means we have to ask the resident directly for these questions. So who's the best person in your facility to get this information? So up on the screen, you have a couple, of those new items: the health literacy, the ethnicity, the race, the transportation. Those are all resident response questions, but don't forget about the old ones that were still there. We still have your BIMs, your pain, your resident or your activities, and your PHQ 2 to 9. Those are all still there as well. The resident participation in the discharge planning. The resident is now intertwined all throughout that assessment that we are doing.
Great. All right, Stacy, thank you so much. We're going to move on then to number 9 in data transfer. So CMS has boiled down the required information to be provided upon transition really to a reconciled medication list. So Megan, please share the logistics surrounding who's to receive this information, when and how it is to be provided and documented.
Yeah, sure. So we have 2 new questions added to the PPS discharge MDS, and both of these will contribute to 2 new publicly reported quality measures, right? So there's transfer of health information to the provider, and then we have transfer of health information to the patient. These measures report that percentage of patient stays with a discharge assessment that will show that a current reconciled medication list was provided either to the patient and the family or caregiver, or to the subsequent provider, of course, depending on where the patient is being discharged to. So CMS has said that they want this to begin being publicly reported on with that Care Compare refresh in October of 2025. And really the takeaway here, and the question that I want all facilities and their teams to be asking themselves, is who's going to be responsible for providing that medication list to the patient or the subsequent provider, and where will this documentation be stored, right? So where are we going to house this particular documentation? We'll absolutely need that documentation in the medical record to support not only who provided the medication list, but how it was provided. Was it verbal? Was it written? And then when was it provided to the patient or the provider?
Thank you, Megan. All right, on to number 8, social determinants of health. Mark, please fill us in on the intent and the details behind these questions surrounding the social determinants of health.
I think Stacy did a really nice job talking about the voice of the resident. And that's really what we're looking for, is the voice of the resident, but not just the questions, but who's answering those questions. And CMS has let us know that there are discrepancies in underserved populations. So I think they're trying to look at, where are we from? What are our social groups, our economic stability, our race, ethnicity, the neighborhoods that we're from. So really quantifying, who are we? One of the things that I'm hoping they take away from this also, and I think other people are as well, is what are they doing with this information? So I look back into my training, and granted, this was years ago when I was in physical therapy school, but studying how groups heal, how groups interpret pain, how groups have support, all those things. I'm hoping when they're looking at stuff like discharge outcomes, they roll these things into them. So I think there's lots of information there, and I think it's very important for us to understand that not all groups have same access to service, and we need to find ways to address that. The other thing that comes in is one of the new items on the value-based purchase is the dually eligible patients, and CMS will be measuring how many dual eligible patients SNFs have, and there will be rewards based on that dual eligibility. So I won't share too much about that, but I think it's important for the providers to understand that it's more than just a question. It's more than something that we race through. It really is something that will probably determine more reimbursement in the future. And hopefully like I said, in the functional outcomes, it will help determine the algorithm that the government's using to really look to see if we're doing our jobs. Is that one of the things I look back and I think in all the years of experience I have is skilled nursing facilities are all trying to do their best. I haven't been in one that's not trying to do their best, and they're trying to provide appropriate services. They're looking for interpreter services. They're looking for those activities, dietary menus, stuff like that. These are those questions that will help inform us of how to better serve our residents and really make us better providers. So this is a very important step. And over the last 30 years or so, we've seen questions that have been added to the MDS to help inform us of what type of residents we're taking into our facilities. And I think this is another important step in that direction.
Great. Well, thank you, Mark, for that. Okay, and we're going to move on. Number 7. We're going to talk a little bit about the staffing requirements. So the industry has been anxiously awaiting CMS's staffing mandates, which we now have seen the proposal for. It includes a potential 3 to 5 year phase-in of 3 hours of nursing hours per day and 24/7 RN coverage within 2 to 3 years after the rule is finalized. Staffing reporting and monitoring of coverage has many implications. Stacy, please share some of the critical areas of staffing and updates that we need to be mindful of.
Yeah, thank you, Susan. That was a great introduction for this topic. It's huge right now, right? With the new proposal, there's been lots of noise about it. Everybody's stressed out. Where are we going to find this staffing? So there's a couple of things that I really want to focus on. One, it's not simply just looking at the number of staff you have. It also looks at the acuity of your residents. And how does CMS know what our acuity is? It's based off of our MDS. And you'll see a lot of these topics that we're talking about, they're going to go back to your MDS. Your MDS is becoming more and more important in your facility. So they're looking at your staffing that you have in your facility. They're looking at the acuity of the residents that you have in your facility. They're looking at the turnover, and not just turnover of your nursing staff, but they're also looking at turnover for your administrators, right? Looking at the turnover of other important support staff that are in your facility. I think we can all agree that the more turnover that we have, the harder it is to have that consistent care for our residents. The more turnover that we have, the harder it is to get those processes in place and have things in place so that we can have that consistent care. And the less staff we have, the harder it is to take care of our residents. We don't need a study that tells us, that the more staff we have, the better care we can provide. That's a given. We know that the more staff that we have, the better care that we can provide. The problem is, where is that staff? Right? I think that's the biggest struggle as I've been in facilities, especially over the last couple of weeks. That's the biggest thing is, where do we find these staff? Starbucks, if their staff says, hey, we want to get paid more, what does Starbucks do? They simply raise the cost of the product that they're selling. We don't really have that option, because a lot of the funds that we get, majority of the funds that we get, are from government entities. So because of that, we can't just say, oh, we'll just increase our prices and then we can pay you more. So facilities really have to start looking at creative ways of retaining their staff, and thinking of ways, what is going to make somebody want to come to work? What is going to make them want to be there and provide the support to these residents? How are you going to help them have that job satisfaction? How are you going to help them have that work-life balance? It's really going to come down to being more creative with the ways that we're retaining staff, rather than just saying, well, we need to give everybody a raise. That may be part of it, but what else can you do as a leader in your building? What else can you do as the support staff, as an MDS nurse, as a floor nurse, as a DON? What can you do to help your staff want to stay there and want to be there? Now, the staffing is going to impact so many things. We know it's already reported on our 5-star rating system. We know that is publicly reported to help the public decide, make an informed decision. Where can we have our loved ones stay, because we can't provide the care that they need anymore, and we want the best care. How are we going to know that? We're going to look at Care Compare. We're going to look at those ratings, and to be able to tell where our facilities are. It also is going to impact our value-based purchasing program, which we know if once they add it to those programs, eventually it's going to be tied to payment penalties or payment reductions. The next slide shows the Care Compare. It's just a screenshot of what it looks like on Care Compare. It's just like when you're going to search for a car, you can go on there and you can actually click a couple of facilities to compare side by side to see how they compare. You can see the star ratings and all of the different domains. It's a very good site for the public, and more of our information, more and more of our data is being reported there, including our staffing.
Hold on, let's just go back to that really quickly if we could. Now, while this didn't make our #1 on the list, quite frankly, in the future, it could and maybe should. And when CMS released their intentions earlier this month for staffing, they took a 3-prong approach, and they're looking at increasing RN hours. They're looking at RN coverage for 24 hours a day, and then more frequently assessing our staffing needs. So I think what we need to do is be very mindful of these upcoming issues. One of the things that I think we need to do better and is really advocacy. We have some groups that have advocated for us, American Healthcare Association, APAC, and even some of the vendor groups I know have been very active in advocating. We need to be active with those groups right now in order to make sure that the government understands that unless there's a pay for on this, how are we going to pay for these services? It's not that we don't want to provide these services, but there needs to be a pay for. And like Stacy was saying, we don't simply just raise our prices. We don't have that liberty. So while this is in the middle of the group right now of the top 10, I'm certain it's going to make its way up the chart pretty quickly unless people are really mindful, they're active in their communities, they're educating their legislators. Those are the people who make the decisions for us. They're educating our payer groups, those third-party payers. And I think that if we start doing that now, we'll have a much better result. And when you see that call to arms from our advocate groups, you need to respond. Otherwise, this will be a huge issue in another year or two. So,
right. Definitely. If you think I can't do anything about it, there are so many ways that your floor nurses, aides, MDS nurses, everyone in the facility can respond to that call for action. everybody can put their input in. The more that CMS hears from us, the better, because they're not in the trenches. They don't know what's going on every single day. So we can certainly advocate for ourselves. And I like, Mark, how you said it's kind of three-pronged. They talked about how they're going to start it's going to be part of the survey more intently now. They're going to be looking at that a lot closer. But they did mention that there will be, there could potentially be some ways that they can help pay for or get, scholarships or whatever to help staff to be trained so that we can have more staff. And another thing you can do as a frontline worker or as an operator is advocate for that and talk highly about where you're working and how people can come in and the job satisfaction that you have, so that we draw other people to our industry instead of always talking negatively about it.
Absolutely. We need to be our best advocates. We need to let people know about the great work that we're doing. First of all, so that we can continue to do that and we can care for those residents who really do need our help.
Great points. This is very hot topic. It's on the news every moment. So
Getting hotter. It's getting hotter.
It is. All right. Oh, now we're going to go to this is another big question of the day. The dashing threshold, number 6. So CMS continues to drive us towards thorough assessments of our patients. This allows us to appropriately devise our plan of cares. It helps us with interventions and reimbursement, as noted by the increased completion requirements this October. Dashing of assessment questions indicates the inability to assess an area of care. If we don't know what our patients need, how can we adequately provide the care? So let's go to another polling question before Megan jumps into some clarification around dashing these days. So here's our polling question number 2. Is the dash threshold looking at the completion of only section GG? We got yes or no. Think about that for a second. It's been around. We've been talking about no dashes for a long time. And Megan, I know you're going to talk about this. This is much more than just what we've been used to. I'm not going to give away the answer. But
yes, much more.
More than what we've been used to. I know you'll help us understand this, but Ken, we'll wait to dive in until we see the result of the polling question.
Okay, it looks like we've got about 60% of our folks who voted. Appreciate that. So let me end this poll. We'll share these results. So just for folks who are listening on the recording later, the question was, is the dash threshold looking at the completion of only section GG, yes or no? Looks like we've got yes, 4%, no, 96%.
Very good. Very good.
Great.
All right. So yeah, so no, we're not just looking at section GG, but let's talk about the threshold first. So currently that threshold sits at 80%, meaning 80% of the MDS assessments completed must have 100% of the qualifying fields filled out and not dashed. However, as Susan mentioned, we're getting ready to see an increase in that threshold to 90%. The change timeline for this is fiscal year 2026. And if your facility isn't meeting that 90% threshold, you'll be facing a penalty of 2 percentage points on the fiscal year annual payment update. 2 percentage points doesn't sound like a lot. It's a lot. It could end up being financially really detrimental to your facilities. So on the next slide, we have a sample of the report that I would really like for all the facility teams to pull in order to check current and past performance with the QRP provider threshold. So in iKeys or in Simple LTC, you can go to your Casper reports. You can request this SNF QRP provider threshold report. And for each fiscal year, it will show you the data collection start and end dates, the total number of assessments that were submitted, and then of course that number and percentage of those that were submitted in their entirety. So if you pull this report and you're flirting with that 90% threshold, strongly recommend that you take a look at the MDS items that are being dashed, because like I mentioned, it is a whole lot more than just section GG there's just many more items. So this information that you can see, this table was pulled from the CMS table of data elements that are used for that annual payment update determination. And this is just a very small portion of that document. So in the table, we can see that these new items in section O will contribute to the dash threshold in either that PPS 5-day MDS or the PPS discharge MDS. And then as we move to the right columns, we can see the X's indicating that CMS will use that information beginning in Q4 of 2023, October 1st, with that new MDS version 1.18.11. So I strongly suggest navigating to that CMS website, take a look at the entire table. It was far too large to include in this presentation, but you'll definitely want to familiarize yourself with all of those new MDS items that have been added to the list. We're talking about items throughout section A, a lot of the new items or the revised items from the old MDS item set to the new. So we've got sections A through D, section J, K, N, O, and those are just the new sections that have data elements that are going to be required. So in addition to section GG, section K with the height and the weight, and then section M with those pressure ulcers. So again, if any of these items are dashed, really consider looking at your process for getting all of that information. Make sure you're not dashing so we don't have, unnecessary items counting against that threshold percentage for your facility.
And real quickly,
I was gonna say in very practical terms, I look at it and say, when you have more dashes, the dashes simply mean you don't have the information or didn't assess it. When I don't know. Yes, I don't know. Yeah. So as a former operator myself, I always felt that put me more at risk during survey as well, because my care plan was less likely to be complete if I didn't have all of the information. So while we look at this as one of the reporting programs that the government is monitoring, there's also that survey risk and the survey issue, and quite frankly, the care issue. Are we providing the proper level of care if we haven't really completed the assessment in its entirety? Does your team know what to do from day to day? So while we look at this as a reporting issue, I look at it as a survey issue, which always to me means a patient care issue potential. Sorry, Stacey, go ahead.
Yeah. So, and what I always, if you've ever taken any classes from me or ever heard me talk, I will beat this horse until it's dead. Be proactive. You know when the ARDs are happening with the MDS, you know when they're coming up. So gather that information. Gather it during that look back period so that when you sit down to do the MDS, you have confidence that you don't have to dash because you have all of the information. So you're looking at the weight. When was our last weight? We're looking at our height. We're looking at the skin. We're looking at the catheter. We're looking at all of those things during our look back period. And it doesn't mean that has to be the MDS nurse that's doing all of that, but as a team, and we're validating the documentation so that we have confidence we don't have to put dashes. We don't want to put dashes, not just for the QRP, but like Mark said, there's so many other issues with putting dashes in the MDS. So be very proactive. Don't wait until after the ARD and just say, it is what it is. That's what we have. I can only code what was documented, right? Be proactive during that look back period.
Great. I think it's a great example of the importance of educating the entire team on their role and how to help you be prepared. If they understand how important those weights are and all the other information that's going to be answered, that might help. It's a team effort for sure. Thank you guys for clarifying. Yeah, that's great. Okay, we're going to move on to number 5, the value-based purchasing program. So it's tough to keep up with, what items are currently being assessed that will impact us with future reimbursement penalties. Historically, we focused on decreased rehospitalization, but Mark, please help provide us some clarity on what outcomes are being used in the value-based purchasing program, the timing of them, and the potential reimbursement impact.
This is a big one. This is always a big one because it started off as a pretty simple measure. We were looking at rehospitalization. We were looking at either a performance benchmark or we were looking at improvement. And that was it. That's what we were being judged on. And quietly in the background now, we have more and more measures that are being added. So as far as I can tell, by my count, by the year 2028, we should have 8 measures rather than 1 measure. So it really complicates things. The other piece is this was strictly, as far as the payment or penalty, for our skilled Medicare patients. It was based on the rehospitalization. We're starting to mix some of these measures. I believe in pay for performance. I think it's a good thing. I've been part of several organizations, and we're constantly trying to figure out what the best performance measure is, what the right outcome measure is. Well, the government stepped in and said, here are our outcome measures. Here's what you're going to do for payment. Here's what you're going to do that could potentially cause a penalty. So I think it's important for us to understand that we're switching from all-cause readmission, hospital readmission, what they're calling a skilled nursing facility within state, potentially preventable readmissions. It's a mouthful. So really what it is they have their algorithm. They're figuring out which conditions are potentially preventable, and they're going to measure us based on those. Is it a good thing or a bad thing? Well, I think it's a great thing for our residents. I think it's a great thing for our industry, because for a long time we've talked about really treating in place. You know, if it's not really an emergent issue, not something that a resident really needs to be sent to the hospital for, can we treat them in place? And CMS's opinion is, for a lot of those conditions, yes, and we should. It's less detrimental to the resident. We get better outcomes. It's certainly less costly. So I think it's a great measure. It's good for us. And you know, you've seen some of the programs, this kind of on a side note, but iSNPs have made a big entrance into the market. And their big push is to treat people in place, skill them in place. Don't go to the emergency room. And a lot of providers have seen success there. I think this is kind of an extension of that. What can we do for our residents in place? What skills do we need to have? So I think we need to look at our staff and say, do we have the proper training? Do we have the proper staff in place to treat the acuity of the residents that we have? So I think it's a good thing. The second piece is that discharge function score, and it's a brand new measure. This one makes me nervous. Not because I don't think we do a good job, but a lot of people have developed their own proprietary scales. Here's how we measure progress. Here's how we measure it. And quite frankly, not necessarily the greatest measures, because they didn't really speak to what CMS and our payers were telling us were their priorities. Weren't really speaking to the priorities of our residents. The other reason that the discharge function makes me nervous is because it reaches across a couple of the pay for performance measures, the SNF QRP and the value-based purchase. So I'll keep repeating myself on this one. It's a compounding penalty, potentially a compounding reward, but it's something that we need to do really well. One of the other measures that's coming up is that long stay falls with major injury.
That one just won't go away, will it?
It will not. It pops up and pops up and pops up. And that one is in your 5-star measures. It's in your QRP. It's in your value-based purchase. It is one of those that you have to really address. And one of the biggest mistakes that leaders, especially administrators and facilities, make is thinking you can turn that one around quickly, because once you have a fall, it's not coming off your quality measures for at least 275 days. It's there. It's there. So when you have a fall with the major injury, you can't have another one for almost a year before you clear those. So super important. The other thing, and Stacy and Megan and I talk about this all the time as we go into dozens and dozens and dozens of facilities, how often people score this wrong because there are only 4 measures that go into this. And we won't go into those measures today, but you have to make sure you code this one correctly, because a serious injury is not necessarily categorized as a fall with major injury. You have to know what goes into this. So it is a long stay measure as well. So another one we're combining, the short stay and long stay. Then we have the long stay hospitalization per 1,000 resident stays. So clearly measuring if our long stay residents are going back to the hospital for observation or being admitted, super important that we are able to treat in place. That we're not only managing the conditions, but in a lot of times managing our residents and their families who sometimes demand to go to the hospital right now. They have to go to the hospital right now. And the fact of the matter, it's for things like UTIs. You know, those things that we really could do some labs, could treat in place. It's just one of those things we have to be able to manage better. And the government is telling us, you will manage this better. So I think it's a fair measure. I don't like the way that they're combining the measures so that what's in the SNF QRP and the 5 stars now in the value-based purchase, I think that muddies the water.
It could be good though, because if you're really good at all of them, then you'll do really good in all of the areas, right?
That's true.
On
You're
the
either
opposite
really good,
end, yeah.
You're
The
either really
opposite end,
good
you're bad.
or you're really bad. So there's no in between here. You're good or you're bad at some of these things. And so our advice obviously is be really good at these things that we're telling you are crossing the measures. Nursing turnover is being reported. Fortunately, this is, and fortunately and unfortunately, like that last conversation, this is also the same measure they're using on your 5-star. Now, we've talked about the 5-star over this last year quite a bit in some of our webinars and podcasts and everything else. You've got to pay attention to that because not only do these measures now cross over to payment, or they're paid for performance measures, but that's where people are going to get information about your facility. And whatever's on the internet is true, right? So if I pull up a review and it says I'm a 2-star facility, you are a 2-star facility to that person who's looking you up on the internet. And if you have competition in the community, you know, it's going to be difficult. So you got to pay attention to these measures. You got to know these measures. You have to manage each one of these measures because it won't just hit the value-based purchase. It'll hit your other measures and actually your perception in the community. So serious stuff. There are some great tools out there. And we added this value-based purchase fact sheet. You know, CMS, for all the complaints we could have about CMS and the things that they do, over this last year, they've provided some really nice tools. You know, they've had videos that you can go and watch on how to do assessments. They have fact sheets. They have technical guides that will really walk you through what the measurements are and what's included. So sometimes I think we ignore this, hoping that our EMR just tells us what to do. And your EMR is great at collecting information. And we have, you know, Simple and some other groups do a really nice job of collecting information and telling you what it looks like. But we still have to take that extra step and understand why these things are coming up like they are, what we can do to prevent negative outcomes. And I think this fact sheet is another step in helping CMS say, hey, please manage this program. We're giving you the tools. Go use them.
And I would say, Mark, I've seen over several social media platforms, you know, there's this panic mode and everyone's like, do you have a tool for this? Do you have a tool for this? I would always go look at the CMS website first, because they might have already made tools so that you don't have to waste your time. And a lot of them are really helpful. Like they have pocket guides for section GG. They have algorithms and decision trees. They have videos, all sorts of things. So I would go there first and see what tools, and that's coming straight from the horse's mouth. So that's going to be your best, most accurate tools are those that come directly from CMS.
I agree. We are constantly talking about sources and resources. This is your source. CMS is your source. That's where all the new information comes from. They are the ones making the rules. They're the ones that are judging us on our performance. Your resources are everybody else that tells you how to use that information. It makes up tools from their tools. It makes up tools from the final rule. So use your sources first. And we talk about this a lot with our nurses and let them know, man, don't go by those rules of thumb. It doesn't matter what you heard on the floor. It doesn't matter what you heard anywhere else, including conferences. You got to go back and read this stuff and make sure you understand the rules, not the rules of thumb. So this is another guide, a fact sheet. I think it's great. And I think it's one of the sources we need to go to make sure we understand our business.
Perfect. Thank you. Here we go.
All right, talk about that 8, up from 1 to 8. And as here's the mystery. How does CMS implement the payment impact? Because it's been pretty clear in the past, you're either benchmarked on your performance or your improvement for rehospitalization. Now, as we get these other measures, we're going to have to learn how they impact our payment as they come on over the next few years. But the other piece is there's no quick fix. So with value-based purchase, you're usually 2 years away from your payment year. So what I'm doing right now impacts my payment in 2 years. The problem with that is I'm then stuck with that for an entire year. So even if you fix your measures that year where you're saying, uh-oh, we're not getting paid what we should get paid, it's too late. Now you can be working and should be working on that same item for the next 2 years, but that window is already passed for your performance. So you're working on your future reimbursement right now. There is no quick fix. One of the things I love that some of our professional organizations have done is they've gone back and started training on the QAPI, using the QAPI. These are QAPI items. QAPI is not just a meeting so you can check the checkbook. If you have a QAPI credentialed person, that's great. It's better to have a good QAPI meeting and actually move the needle, which means your residents get better care. You have better outcomes, but there's no quick fix.
Yep.
So one of the things I always do, and my team gets tired of me saying this, I think, is we can talk about the measures. You can talk about all the measures. You can talk about coding and documentation. And when I was an operator, I literally had some of the regional operators come to me and say, when are you going to fix my quality measures? Fix my value-based purchase? I'm not. You're going to do that by providing better care, by preventing negative outcomes. You're going to document that care carefully, and then we're going to code it properly. That's how it works. So always start with the care. Always make sure your residents are receiving the care they deserve, that your staff has the skill that they need, that the care plan's appropriate, and you're not waiting for the MDS nurse at the end of a quarter to update your care plan. Assess that resident and change that care plan when it's needed. That's what will change your value-based purchase, as well as, quite frankly, your survey results.
All right, Mark. On that note, we're going to move on to number 4, SNF Quality Reporting Program Changes, or QRP. So quality measures that are being utilized for QRP continue to expand. Stacy, please help us understand which quality measures are coming, going, staying in place. And this is another potential reimbursement takeaway situation that we need to pay close attention to. So Stacy, help us out here.
Yeah, thank you. So with the SNF QRP, we've talked a little bit about it with our dashing thresholds. This is something that keeps coming up over and over again. Our SNF QRP, our value-based purchasing, and we keep talking about them. We keep bringing them up, 1, because they keep changing, but 2, it's important because they are impacting so many different things that go on in the facility. So they are going to adopt 2 new measures. They're going to remove 3 measures. They're going to modify one of the measures, and then they're also going to change the reporting threshold, which Megan already touched on that. So you have 16 QRM measures that are going to impact your fiscal year for 2024. So fiscal year 2024 starts October 1st of 2023. So that's here in just, I think Ken said, 17 days. So we're getting really close to that time. So it can be overwhelming if you're looking at this and you're saying, oh my goodness, these are all of the things that are going to potentially impact some payment penalties if I don't have this information reported. So it goes back to, where is this data coming from? Do we have processes in our facility to make sure this data is captured and accurately reported? Some of it is reported through the MDS, some of it's through your NHSN. Do you have a process in place to collect those vaccinations? Do you have a process in place to make sure that you have all of the data on the MDS? So 16 measures are in place right now. Again, go to that CMS website. That's where you're going to find all the information. There are technical guides. There are any updates that they have, any resources that they have. If you scroll down to the bottom of the page, that's where all the links will be for the different guides that will help you understand this. Always, always go to your source first, CMS. So making hits, not just the tunes. So it's important to understand these dates. So on this slide, you'll see all of the different dates. We've got our discharge function score that will start fiscal year 2025. You've got your vaccination measures that will start fiscal year 2026 for your patient or residents, and fiscal year 2025 for your healthcare staff. You've got your data completion thresholds, which that's what Megan was talking about with your switching up to 90%. They'll start collecting that data in calendar years. And then the transfer of data, which we already discussed a little bit as well, that's collecting that data, and that begins this October. What do you need to know about this? Why is it important for you to be aware of these? As an operator, I want you to think, or as an MDS nurse, as a DON, whatever your role is, all of these things are important, and you can't rely on one person to manage this or one person to understand it. This is where it's going to go, educating your entire IDT team on what an MDS is, what an MDS impacts, how we get that information, talking about NHSN. Does your staff know what NHSN is? Do they know why it's important that we have this information? Do they know why we need them to respond timely to questions that we're asking them? I am a huge proponent of education. The more education that your staff has, the more training that your staff has, the more information that they have, they can help you reach your goals. They can help you get where you need to go. Gone are the days where the MDS can sit in their silo and code the MDS based on documentation without ever leaving their office. We've got to be proactive. We've got to understand these measures so that we can go and collect the data, so that we're not getting penalized for not even reporting the data, let alone what the data is telling them.
I think it's important for people to understand that we're literally going from the threshold data. We're increasing the completion rate of that, but that was our one measure, and now we have 16 measures. This could really blow up and become something that's much less manageable. Right now it's easy to manage because you're pulling one report, you're looking at it. Like Megan said, though, if you're getting close to the threshold, you better really button down and get it done, because it's very difficult, if you have much of a skilled census, to bend the curve back up the right way.
Yeah.
But there are a couple.
Yeah, go ahead, Mark.
I was gonna say there are a couple of measures on here that should give some people some pause. And while we all want to prevent the spread of COVID, and we understand that, you know, it comes in waves, it comes and goes, there are a lot of opinions about the vaccination too. So when we're looking at this vaccination measure, it's not just simply a matter of going and doing it. You know, who is your infection preventionist, and how are they educating your staff and allowing them to see that it's on us to protect our residents, and that's why we're being asked to vaccinate. And we can have political opinions and other opinions about vaccination, but unless you're managing the process, it's going to be difficult to reach these measures, because in a lot of places, people are simply refusing to be vaccinated after a certain point. So if we're being required to vaccinate as per the latest CDC recommendation, there's some work to be done, and that's every day. That's every day. And Stacy brought up a really important point, that one person is not a process. So if you have one person trying to manage this, and if it's your MDS nurse, you're having manage all these things, you're in trouble, because there's no backup, and because you don't have team collaboration, and you don't really have a process. You just have somebody that's worked extremely hard trying to manage all these measures. And as you've seen, they're growing and growing and growing and growing. And where the MDS and with RUGs was easier for them to manage as far as the outcome and the payment, because it was therapy driven. Now with PDPM, there are 188 measures on the MDS that they have to be responsible to code correctly. There are 16 measures for the QRP. There are 8 for the value-based purchase. It's growing, and it requires team collaboration.
And
That's-
don't wait. Even though these dates are down the road, do it now.
Yeah, that's one of my, going back to what you said, Mark, one of my favorite things to remind teams of and coordinators especially is that their primary job function is in their title. So if you're a coordinator, you are coordinating a process, not completing the entire process yourself. So Stacy, when you said, one person is not a process, I really want teams to keep that in the back of their mind because it really does take everybody getting on board to make sure that we have all the proper documentation and make sure that things are being reported appropriately.
Okay. Great job, guys. So much. Let's dive a little bit more into the new discharge function score. So there's been just an enormous amount of buzz about this, and we've talked about it several times already, specifically the expected discharge outcome score. So many questions about this. How is it calculated? How can we ensure the expectations are accurate for each resident? And how do we know where we stand? Mark, please fill us in on what we need to know.
I am happy to do this one. I love this one. It's something that I'm actually pleased to see because I've been part of reviews in the past, in past jobs where, people would present outcomes to me and they wouldn't be tied to my quality measures and they wouldn't be tied to any of the outcomes that seem to be important to my payers and to my residents. They just were numbers. And while the numbers look good, it didn't seem to get me anywhere. Well, with this new discharge function, there are a couple of things that still make me nervous. One is the government's going to set a benchmark and they're going to use their algorithm to tell us what the expected outcome should be like, especially if we leave information out. So we better be very thorough on this measure. But the good news is, and I believe there's another slide, the measures are almost the exact same as the measures we use for our section GG scoring, for PDPM, for nursing, for PT, for OT. So most of these should be very familiar. There are a couple different, I think not many different, but one is that you can wheel 50 feet with 2 turns as part of this, not just walk. So one of the things to keep in mind is if we're not good at scoring these things, we're in trouble. And one of the buzz constantly over the last 6 months has been section GG. And you mentioned at the beginning of the broadcast, Susan, section GG, section GG, section GG. We even did a webinar called section GG and GG and GG, and people listen, but section GG is not new. What we've done though, in a lot of places, I actually talked to a therapy provider who told me that they have clients that are trying to get them to contract to just dump their therapy scores into the section GG for the MDS and just use therapy scores.
Oh no.
Which is totally against what the REI manual asks us to do, right? It's a team collaboration. You're taking it from multiple sources. But it's not necessarily the facility's fault, because in many states we've been required to continue to track section G for Medicaid payment to establish a RUG. And then we had section GG, so we're relying on nursing to do that. It's been very difficult to balance the two. So what are we going to do now that we actually have a discharge function score that's based on section GG, which is driving our QRP and value-based purchase? We've got to get it right. Now, again, there's another book for this, another source from the government. It's all good stuff. You need to understand how to score these. The other thing is how we're going to track and who's going to track the patient performance. One of our weaknesses is that we've relied on CNAs to track section G while we try and use UDAs and other assessment tools to track section GG. The problem is we don't get that information enough. So if we're looking at usual performance, you better have more than one score a shift if they're doing it 4 or 5 or 6 times a shift. We have to figure that out. The other thing is establishing a proper baseline. If you don't establish a proper baseline and your baseline's too high, and generally when your therapy is scoring the baseline, they're probably going to fudge on the high side because they're the best at getting residents to perform, right? We know that. That's what we're trained to do. you're not going to have much of a change if your baseline's too high. Now, it needs to be accurate. So I'm not saying move it down. I'm saying accurately score their performance. Now, Simple and a couple other people, I'll let them talk about this slide, but it's going to be important that you're tracking these things throughout the months and throughout the year, because by the time you get to the end of that measurement year and into a performance year, it's too late.
Thank you, Mark. Ethan, are you on and able to take this
Yeah.
slide? Yeah.
Yeah, for sure. I wanted to
Thank
call
you.
out just real quickly. I know we have a mixed audience here, but for those that are Simple clients, this is a brand new measure with 5-star potential impact, right? So it's a big deal. It's something that we're working on. We got the specs last week in the QRP users manual. So I'm digging through them as well as all the other October 1st changes. But I did want to call out a couple of places where you can go now. This is a new measure, but it's also kind of the evolution of how CMS has been looking at section GG. We've had SO24 looking at self-care and SO25 looking at mobility for some time now. And so if you are a Simple client, we're providing some analytics around this to show you for my ongoing stays. Let me see those residents that are ongoing so I can see the entry score and then also that expected discharge score that CMS has for me. As soon as I submit that 5-day, CMS has calculated that baseline, but they've also given me an expectation. So if we don't know what that expectation is, it's going to be a lot harder to hit, right? But if we are in the application looking at that expected discharge score, that's going to provide us a goal to hit. So a couple of places, if you're a Simple LTC user, to look on the dashboard in the clinical section, function scores. This is the best place for you to see a list of all your residents, those ongoing stays, where you started and where CMS expects you to be by the time of discharge. Also, as soon as you upload a 5-day, the first thing that we're going to do is we're going to scrub it, give you that analysis report. If you give us a 5-day, we're going to give you at the very top that entry score and expected discharge score. So you know before it even goes to CMS, what that expectation is going to be in that discharge goal. And then on the back end, if we hit it or not in this dashboard in the clinical section. So we're working on this new measure, but to the extent that you're familiar with SO24 and SO25, you're going to have a better understanding of how they structure this and how all the parts play together. So get in there today if you are not familiar with it and just start playing around, seeing how are we doing with these ongoing stays and even look back. Are we doing a good job of hitting that expected discharge score on completed stays as well?
Ethan, I think this is an awesome tool. One of the things that we haven't been required to do is really achieve an expected outcome. This is something brand new for the field. And in the past, we've been asked to set a goal related to mobility and self-care. And that goal could even be at the baseline and it was good enough. They didn't have to really have a performance measure. So this is something brand new. And I think it's very important that people understand that it's an elevated expectation. It's brand new. You need to dig into this, like you said, and understand what the expectation is. Otherwise, it's going to be very difficult to achieve. And so again, when I go back to my QAPI meetings, I think this is something I need to be watching like a hawk. Otherwise, it's going to get away from me.
And Mark, help me with this, but I believe that I'm understanding correctly that how does CMS come up with an expectation? It's not just from your baseline. It's from looking at what was the prior level of function? What are all the comorbidities? What all of the answers that we've provided before are going to tell CMS, well, this is what you should expect. They weren't walking before, they're not going to walk in the future. But if we code that wrong, or if we say that they were living at home independently before, and that's incorrect, that's going to set up a false expectation. Or if we don't include the fact that they're on hospice, things like that. Everything is going into the equation. It's not just getting that baseline GG right. Am I correct on this?
You are. There's lots that's going to go into it. It's a complicated algorithm. It's going to be taken from multiple fields. So, but they are going to estimate what the outcome should be. Yeah. Now, for those facilities that have few Medicare residents and few skilled residents, it might be more difficult, like some of the measures are, to achieve that, because we know that all residents don't achieve the expected outcome. They don't, for whatever reason, even with our best efforts. So I think on average, we're just going to have to look at it that way. On average, are we getting and exceeding those outcomes? And that should always be our goal, is exceeding those outcomes, because you're going to have some residents that don't meet the outcomes. But it is very complex, and I love this tool. I think it looks great.
Awesome. Thank you, Simple. Thank you, Mark and Ethan. All right, we're moving on our countdown. We are up to number 2. Oh boy. State-specific changes coming October of 2023. So one of the biggest changes to the MDS this October, as you all know, and we've been talking about, is the removal of Section G, which assessed our basic ADLs and which were a key driver in many states to the Medicaid reimbursement model, as well as quality measures in our 5 stars, right? So this has left some states, many states, scrambling to determine a new Medicaid payment methodology or a new way to capture Section G information. So Megan, you draw the lucky stick here. Please share what we need to know at this point and what we need to watch out for.
All right, so this really is the question: to OSA or not to OSA? And I really, it's funny that you said drew the short stick, because I like this one, right? Number one, you need to know what state are you working in, right? Some of you probably multiple states, but you need to know what state you're working in first. Then we need to know what they're doing come October 1st. So the new MDS item set, as Susan said, goes into effect on October 1st. So is the state that you're working in going to require the use of an OSA, and when are they going to require that item set to be completed is really what we're looking at here. So since every state is different, we're not going to be able to go into detail today about every individual state. I can feel the chat like blowing up right now. I haven't seen it, but I can just feel it. But we do have a list here of states that we've confirmed will be utilizing the OSA to calculate RUGs for Medicaid reimbursement. And I probably should have said it before now, but if you don't know what an OSA is, it is an optional state assessment. We do have a recorded webinar that we put up last week on the QRM website that goes over the OSA item set. So I recommend, if you're not familiar with that item set, just navigate to our website, grab those handouts so you can start to familiarize yourself if your state is on this list. It will help you get a good idea of the additional workload that's going to be required of your MDS coordinators and those teams. In general, the OSA is, of course, like a condensed version of the current MDS item set, and it only contains items that drive payment under RUGs and those RUGs-based systems. So when we joke about Section G going away, and I think on every webinar that we've done thus far, we're like, it's going away, but not really. So in the OSA, if your state is on this list, you're still going to be responsible for, and this isn't everything, but you will still be responsible for the 4 late loss ADL items from Section G. They are going to be retained in that OSA item set because, of course, they're required to calculate RUGs for Medicaid reimbursement.
Megan, I'm just going to throw this out there in the chat. There has been 30 people asking, what about Texas? So just answer the Texas question. Is Texas?
I'll be happy to.
OSA?
No, Texas is not going to require an OSA. I think every time we talk to really anybody from around the country, they're like, oh, but that Texas Medicaid reimbursement system. Oh my gosh. I don't mind it. It was the first state that I learned. So it's not too tough for me. But no, Texas is not going to require the OSA. They are going to require some additional information that will have to be put into the long-term care online portal. But no OSA for Texas. I think there was some chatter maybe like a year ago or something that we were going to move to that, but no, not happening.
It's funny when you said that it's going to blow up down below. Oh, it's blowing up. It's blowing up.
I could feel it. I could just feel it. Yeah. So if your state, with the exception of Texas, if your state is not going to require the OSA, you might be moving to a PDPM model for reimbursement, for Medicaid reimbursement. So you'll need to know what components they're going to reimburse you on and how that's going to impact your current process. How will your facility go about getting all of the documentation needed to support the capture of those case mix groups, right? Not
And I think-
Texas.
I
Texas
think
is not
it's-
OSA and also not PDPM.
Yes, I think it's important too to know, I've seen a couple of questions pop up about what about California and some of these other non-case mix states? If your state was not case mix before, they're most likely not going to transition to a case mix state because it just complicates things. So if they weren't requiring case mix before, they're not going to require it now.
Right.
Great point, Stacey. So of course, there lots to digest here when it comes to state specific changes. So we have some CMI wizardry happening at QRM. And they've really taken all the guesswork out of, what is my state doing? So we have this awesome interactive map on our website. It will allow you to just navigate, click on your state. When you hover over your state, I think it will bring up just like a basic overview of what's happening. A brief video from our CMI guru, Matt Cameron, explaining that reimbursement model. And then of course, as always, the source documentation. So it will have links to each state's website where we obtained all of the information. And I mean, it really doesn't get any better than that. It's a map.
And he's updating it. Yeah, and he's updating it like daily. He is in close communication with each state and has the source documentation, as Megan mentioned. So you access it through our website, qrmhealth.com. Okay, and it's in the chat as well, how to access that. Thank you, Megan.
So, when you're saying Matt was updating it daily, he is, and the information is not easy to get. Some of the states are holding out. The other thing to keep in mind is you need to check this pretty frequently for those states who haven't released their information, because some of these are waiting till the 11th hour. They literally are holding the information and we're getting releases whenever. So we'll continue to update this. I know he'll continue to work on it, but if you don't see the updates you're after, continue going back, clicking on your state, checking it out, and Matt will update it as soon as he can find the information. And he does a great job searching.
Yeah, and we have more than just Florida and Rhode Island and the states that are popping up here. We've got, I think, every single state except I think Vermont is kind of questionable right now. So seriously, if you have a question, check it out. I hope it can help you. And then just another little plug for Texas, what in the world's going to happen over there? Simple's got your back.
Yes.
So I don't know, Megan or Simple, if you want to speak, since we have apparently so many Texas questions on at the moment. Does anybody want to take that real quick? I know it's in our webinar, in our website too, but Megan, do you want to take that?
Yeah, I mean, so I know that Simple is working on, if you're a current Simple user, you know how simple it is to enter all of your LTCMI information. But they're, currently working on getting, fields populated in and making it, as streamlined as possible for you to enter in the fields from the MDS that will not be pulling over. So, of course, Section G is one of those, right? We're not going to have Section G in the MDS item set, but you're still going to be required to have those 4 late loss ADLs to calculate RUGs for Texas Medicaid. So I don't know if Ken or Ethan or anybody else wants to chime in on that, but I do know that is in the works on the back end for them.
That was a great answer and right on the money. There are 55 fields that TMHP is going to require you to fill out. We're going to take 35 of them and pre-fill them for you to try to take as much of that load off as we can. I see a lot of questions. What's it going to look like? I'll just say real quick, next Thursday, September 21st, we'll be doing another webinar going into detail just about LTCMI. So if you're excited about that, or even if you're not excited and you just need to know, join us next week and we'll go through it.
Yeah, just because you're not excited doesn't mean you don't need to know.
That's right. That's right.
It's happening. It's happening.
Thank you, guys. Perfect. Okay, lots of answers. We're trying to get to them. And now, here we are to our biggest hit of the day. Number 1 on our countdown is the PHQ transition from 9 to 2 to 9. But before we get into this, let's go to our last polling question of the day. Polling question number 3. When do you end the PHQ interview now? If the response, here's the question, if the response to little interest or pleasure in doing things and feeling down, depressed, or hopeless are both coded no response, both coded never or 1 day or 2 to 6 days, or either A or B. And I didn't make this up, I promise. So Ken, let's go. It took me 10 times to figure out what in the world are we being asked here. So this is, I'll let Ken work his magic back there, but this is a big shift, right? We know our residents are hesitant in answering these really deeply personal questions. Potentially ending this interview after the first 2 questions appears to leave a lot of critical identifiers of potential depression unknown, which can negatively impact our ability to provide adequate care towards improved clinical outcomes. So Stacy, how can we be most successful with this very important interview? And what do we need to do to understand, or what do we need to understand regarding the implications moving forward with this new requirement of ending the assessment? So let's get the polling answers, and then we'll let Stacy provide us with what in the world is going on here. What you
Okay,
got?
thanks. Yeah, thanks so much, everyone, for responding. Looks like we got close to half our attendees who responded. I'll end this poll, share these results. And just for folks who are listening later on the recording, I want to run down these responses real quick. So the results were both coded no response. We got 34% of our audience saying that answer. Option B was both coded never or 1 day or 2 to 6 days. 20% of our folks responded to that answer. And then the final selection was either A or B. For the majority, 47% of our audience selected that one. So I will let you guys take it from there.
All right, Stacy, what's the right answer?
So we're going to talk about the right answer, but I want to talk about those results. That is exactly why this is number 1. Those results are split, right? It's not a huge margin of the majority who thinks one way or the other. So let's dive into what the correct response is. So first, just to give you a little snapshot, you can go ahead and change the slide. This is just a snapshot of what it looks like on the MDS. So it's changed from that PHQ 9 to the PHQ 2 to 9. So you can see right below those first 2 questions, you have a little line that says, hey, you may potentially need to stop here. So let's talk about what this means. So we're going to break it down. So on the next slide, we have those 2 answers those 2 option questions in the PHQ 2 through 9 that Susan was just talking about. So the first question is little interest or pleasure in doing things. So the question is, have you been bothered by this in the last 14 days? So if they choose not to respond, and then we move to feeling down, depressed, or hopeless, and they choose not to respond, you're going to end the PHQ 2 to 9. And you're going to get a total severity score of 0, and you end it. But what about all of those other questions, right? What about all of those other questions? So here's your other option. This is also will make you end it. If for little interest or pleasure in doing things, they say yes, but their answer is either never or anywhere from 0 to 6 days. So never, 1, 2, 3, 4, 5, 6 days, and when you ask the question, feeling down, depressed, or hopeless, and they say yes and give you a response of 0 to 6 days, that will make you stop the PHQ 2, enter the severity score, which the max your severity score could be at that point would be 2. So they're not going to trigger for depression, and we have to stop. So we're not asking any of those additional questions. This is kind of sad to me. This is really sad to me because our care plans could potentially be incomplete, right? Because what happens if maybe they're not having any issues with a little interest or pleasure in doing things, they're not feeling down or depressed, but what if they're not sleeping well? What if they're not eating well? What if they're acting slower or faster than they normally do? Are we still going to assess that? Or because it's no longer required, are we going to stop? Which means we're not providing the care. We're not providing those interventions to help them have the best quality of life that they could, right? Payment may no longer reflect the actual care that the staff is providing because we only ask those 2 questions, right? So there's a lot of issues with it changing. So here are some things, some strategies that I would suggest to you as you're doing your PHQ 2 through 9. Go and read in the REI manual. There are some excellent interview techniques that you can use. You want to make sure that you are in an environment that they feel comfortable talking to you about the things that are going on, right? I always share a story. I was going in with social workers and helping them do their PHQ 9s. And we would go into the rooms and talk to the staff. I went into one room with a staff member and we introduced ourselves. We gave an introduction. We talked about what we were there for, asked her if we could ask some questions about her mood. And her voice was saying, yes, you can. But her head was like saying, no, we need to get out of here. And so the social worker caught on to that and said, oh, actually, I forgot something in my office. You mind walking down with me there and we can talk along the way. When we get down to her office in a private location, the resident proceeded to tell us that her roommate was her best friend. They did everything together. They she just adored her, but she also said she's the biggest gossip of the facility. So she said, anything I tell you, she's going to tell everybody else. And then I won't be able to go to bingo or to, dining room without feeling ashamed. How many of you have thought of that before? You're asking these very personal questions, and the only thing that is dividing the room is a shower curtain, right? So think about that as you're going into prepared to do these interviews. 1, is the person doing them trained? Do they know how to do it? 2, are they providing a private environment? Do they have a rapport with the resident? Right? These are all very important things. And maybe the resident doesn't want to communicate to you verbally. Maybe they prefer doing it in writing. The REI manual does allow you to issue it in writing if that's what the resident prefers. So lots and lots of things to think about. Now, for me, what I would encourage facilities to do is, even if per the REI manual, we have to stop after question 2, continue to ask those questions so that when we're thinking about the care that we're providing, we're thinking about how to help them live the best quality of life they can. We're looking at all of those things and not just those top 2. So maybe even though it says, stop at this point, we continue to ask those questions so we really know what's going on and we can provide that appropriate care.
I really like what you're saying, Stacy, and I agree 100%. This one just makes my chest tight and my soul hurt, because when we ask those 2 gateway questions, if they don't respond, we're stopping. We're not pursuing the other answers. We're not giving that resident the opportunity to explain their feelings. Now, one of the things we're going to do on September 26th on a future webinar, we're going to go through some of those interview techniques because we think it's that important. The PHQ 2 to 9 certainly could impact your payment, because if they don't answer those 2 gateway questions not correctly, but give you enough response there to trigger the other questions, you're not going to get that $30 to $50 a day to treat those residents and provide the level of care that they probably need. So this is one that really makes me the most nervous. It's why we put it number 1, because not only does it impact our care plan, potentially care that we provide, but also payment. It's one of those things that it hurts to read it. And when they said that the PHQ 9 was a valid, reliable assessment and would properly identify some of these signs and symptoms of depression, cutting 7 of those questions off makes no sense to me. So I think you're right. We need to ask those other questions, even if we can't score them, so we properly care for our residents. And we address this really serious issue.
So I know we've gotten a lot of questions come in. So I think that, Mark, if you could help us wrap up pretty quickly, we could go into a few of the most commonly asked questions. We've got a lot. So do you want to take a stab at a quick wrap up?
I will try. You know that I don't wrap things up quickly, but I will do everything I can.
We're going to put you on a timer. You have 30 seconds to wrap it up, Mark. 30 seconds.
Ready, set, go. Ready, set, go.
That's right.
Go ahead and forward it. Because it's important that we understand all these changes. One of the things I go back to, and you can read the slides, leadership. It takes leadership to help your team move through this transition. So you administrators that are listening to this, you are the designated leader in your facility. You can't defer this to somebody else. And when it comes to delegating, that's fine. Make assignments. I love the who does what by when. That's what I do. But it's still your responsibility to go back and make sure there's a process in place. There's a backup. People know how to do their jobs. Don't assume they know how to do it until you see them do it. The other thing, Section GG, we joked about it earlier. It impacts so much. Don't neglect Section GG. Don't defer it to therapy. Don't defer it just to your MDS coordinator. It's an IDT process. It's a decision. It's usual performance. You got to support your teams if you're going to make this transition successful. So one of the things that I also want you to remember is don't panic. If at 10-1 you don't have everything right, do what you would do clinically. Go back and reassess. Set a new plan in place. Do something different. Go re-educate. You have time. There might be some financial implications, but don't panic. Calm is contagious. We know that from leaders, so be calm. The other thing is focus on the basics. Resident care is your basic. That's the most basic of basics. Taking care of your staff is a basic. So if you want to take good care of your residents, take good care of your staff, have processes in place. Don't leave everything to one person. I saw one of the comments, it was not a question, I was watching some of the comments about one of the MDS nurses. Can you say that again about the care plan? Don't leave everything to your MDS nurse. Make sure the people who are treating your residents are involved in the care plan. The nurses who are providing hands-on care should be providing updates to that care plan because they're seeing what happens to the resident, and it should be an interdisciplinary process.
You got a lot of amen marks.
I'm not even an MDS
I was
nurse.
cracking up.
I'm not an MDS nurse, but you know what? They're asked to do a lot, and your MDS nurse is not the process. Your MDS nurse is your best asset to make sure you're in business next month, that you're coding properly so you get reimbursed, but make sure their workload is appropriate and everybody else knows their part.
Yep.
So leaders, go lead.
There you go. All right. I'm going to keep going because we got some really great questions, and everybody can read QRM service offerings. We do provide, in addition to rehab management, MDS oversight services, focusing on your reimbursement capture, your compliance, and your 5-star, all the performance metrics. So there's also the rest of our service offerings. Our resources can be found in all of our blogs and posts, and we got our website and our Medicare map, Medicaid map. So Simple, do you want to do a quick overview before we get to the questions?
Yeah, very briefly, we're going to jump right into Q&A real quick. But if you've been listening to all of this and you're thinking, oh, we're 17 days from October 1st, I need some help. Like, that's what Simple is here for. You heard Ethan describe some of the metrics that we measure and help folks with. We've got over 5,000 SNFs around the country using something we call Simple Analyzer. We try to simplify some of this complexity. So if you need help with MDS accuracy, compliance, IKey submission, how to improve 5-star, how to really measure, dive deep on those QM ratings and do it in real time in a way that predicts your 5-star and helps you stay ahead of that, this is the way. So what I'm going to do is bring up a poll real quick. So if you want to learn a little bit more about QRM or about Simple, this is how you can let us know. With that, I'll just leave that poll up for a minute to give everyone a chance to respond. And Susan, I'll let you take Q&A from here.
Perfect. So I think, Mark, you were just speaking about the PHQ 2 to 9. Here's a question for you. If the state is staying on RUG-based Medicaid reimbursement, will they still have to do the full PHQ 9 since it is part of the clinically complex RUG? Who wants that?
I'm gonna let Megan take that one.
All right, Megan.
Because she's doing a big head nod.
Yeah, I had a feeling that would be one of the first questions because I saw that a lot in the chat and the Q&A. If your state is going to use the OSA, in that item set, it is the full PHQ 9. Yep.
Okay, very good. All right, and I know that there is, there's been an inordinate amount of questions on GG. What should we do when residents refuse to be weighed? And what about hospice and palliative care that don't get weighed? Is there an option not to dash? Let's talk about the options not to dash all the way across the board. How about that?
I'm going to say this really carefully. Okay. There are nurses that can get anybody to do anything at any time. There are nurses that can get anybody to review or refuse any day at any time. One of the things we need to do is make sure that we're not the problem, we're not the source. And I actually worked with several facilities who had problem with weights. And it really was not only the person that was trying to get them to be weighed, but it was when they were trying to weigh them in the process. So make sure your process is as friendly and as easy for the resident as possible. Make sure you have the right person trying to weigh them at the right time. So that would be the first thing I look at, because sometimes we hate to say it, but we are the problem.
Right. And if they're refusing to be weighed, you have no weight. You're going to have to answer why you have no weight, or
You simply just have to dash that out. If you don't have the weight done within the appropriate time frame, then you have to enter a dash.
But I would definitely, this is going to come up in surveys. I've seen it come up in several surveys. You want to make sure that you're documenting in the medical record why the weight was not done, what your attempts were to get it done, what you're doing about it, all the things.
Yeah, have somebody another time go try it.
right. Oh, and we're almost done here. So one more quick one that was apparently very prevalent was if the patient's only been there less than 12 hours or just a few hours and they discharge, how do they address incomplete information like bathing, eating without applying a dash? And maybe you can speak to those unexpected discharges and the requirements. Anybody want to take that?
You wanna
Yeah,
take
so
that, Stacey?
I'll
Sorry,
speak to a very short stay. So this is why it's so important to know what your threshold percentage currently is and where you typically run, because there will undoubtedly there will be instances when you really don't have the information and you really do have to dash. So if it's a one-off situation, that's not going to put you, I would hope it's not going to put you under that 90% threshold, but it's all the other times. Like Stacey talked about being very proactive and making sure that you've got all the documentation that you need to accurately code that MDS. One is not going to make or break you. Now, if it's the ongoing issue and you're really dashing way more than you should, then it becomes a problem. So for that one instance, you're probably going to have to dash some stuff. But
Yeah.
For the rest,
just like any quality measure, there are exclusions as well. Yeah. So you'll want to make sure that you go to that manual, you're looking at what the exclusions are, and then you dash it because that's what you have to do according to the REI manual. But then you can look at the exclusions and know, okay, this one's going to impact us. This one's not going to impact us. So there's a lot of things that go into that. And Susan, I know we're right at the time, but there were a ton of GG questions and there were quite a few that were very similar. So one thing I really want to say about GG is there is a difference between documenting the GG items and coding the GG items. There's a difference there. When our staff is documenting GG, they are simply just documenting the same way they did with section G. They're just documenting what care they provided. They don't have to know all of the rules when they're documenting, so I think that's people's biggest hang up with having our aides document is they don't understand all of this. They just have to know the definitions of when they're coding, independent, what that means, or they're coding these different items, what does that mean? They are just documenting what they did. Now it's the team, it should be an IDT approach to determine what that resident's usual function was to actually code it on the MDS. And I think that's what's causing a lot of panic throughout the industry is my aides don't know that information. Well, they're just documenting what they did. It's just using a little bit different terminology.
I think that, there's so much more we could talk about. We've got webinars coming up. We've got recorded webinars. We all are here to help you. So we hope you use our contact information. I know there were a lot of questions about what do we need to do on 10-1 with our assessments. Is there something that you want to say real quick about what happens on 10-1 with their assessment schedule? Anything real quick?
Absolutely nothing.
Okay,
Absolutely
good.
nothing. You just continue on with your same schedule. Now your state may have something specific, but as far as federal requirements, you just continue with your same schedule. It's not, you don't have to do a new assessment for everybody.
Okay. And so we want to make sure that you know you will get our handouts. We'll do our best at, answering the questions, getting you a copy of this webinar. And then for more top hits and updates, head to qrmhealth.com. And until we meet again, thank you, Casey. Keep your feet on the ground and keep reaching for the stars. And thank you so much for your time today and extending it with us. We appreciate you and we're all
Thank
here to
you.
help. Thank you,
Thank
guys.
you, everyone.
Thanks, everybody.
What a
Thank
great way to
you.
wrap it up. Thanks so much to the QRM team. Everyone will be receiving a follow-up email tomorrow with a link to the recording and the handouts. Be sure to leverage that, share that with your team. We really appreciate everyone participating today. Thanks so much to QRM and to all our audience. Hope everyone has a great day.
Thank you.
Thank
Bye.
you.
Bye, guys.
Bye, guys.